This recorded lecture will be going over Chapter 36, Care of Patients with Pituitary, Thyroid, Parathyroid, and Adrenal Disorders in the MedSurg textbook. The pituitary is considered the master gland, controlling multiple functions in the body, and many syndromes can result due to pituitary disorders. Tumors of the pituitary gland account for about 10 to 15% of all intracranial tumors. Local symptoms are more likely to occur when the tumor is large and creates pressure within the brain. A tumor of the pituitary is usually a benign pituitary adenoma. The etiology is not clear, but these tumors tend to affect women more than men. Some tumors do not cause symptoms, and they may be identified during autopsy after death occurs from other causes. If the tumor is large enough, there will be increased pressure within the optic chiasm, which, if not relieved, could damage the optic nerve. Local symptoms of pituitary adenoma include headache from the pressure of the tumor, as well as visual disturbances, including possible blindness due to the pressure within the optic chiasm. Systemic symptoms could be vague and progress very slowly. This could include personality changes, weakness, fatigue, and vague abdominal pain. These could be present for years before the condition is diagnosed correctly. MRI and high-resolution CT with contrast media can be used to identify, localize, and determine the extent of the tumor. A thorough ophthalmologic examination should be performed to evaluate pressure on the optic chiasm or the optic nerves. In some cases, the healthcare provider can choose to treat the pituitary tumor conservatively with hormone therapy designed to reduce levels of hormone production. If the tumor continues to grow or presents serious hormonal imbalances, it may be treated surgically or by irradiation. A hypophysectomy, or surgical removal of the pituitary gland, is most commonly performed microsurgically. After surgery, the patient should be kept in a semi-Fowler's position. It is important to note and communicate promptly any changes in vision, mental status, level of consciousness, or strength. Because nasal packing will be in place for 2 to 3 days, the patient should breathe through the mouth. After surgery, it is important that the patient not brush their teeth, cough, sneeze, blow their nose, or bend forward, because all of these actions could interfere with the healing process. Excessive secretion of growth hormone results in gigantism in children. This leads to excessively tall stature because the bone growth plates have not yet closed. In adults, the result will be acromegaly. Pituitary adenoma could increase the release of hormones. Stress and pregnancy are other causes of increased hormone release. Gigantism causes the adult's facial features to change. The lips will thicken, the nose enlarges, and the forehead develops a bulge. The hands and feet become enlarged in adults. The first sign could be that the patient's shoes no longer fit. Signs of prolactin excess include amenorrhea and milk secretion in females, as well as loss of facial hair and impotence in males. Alterations in hormone levels can be detected by laboratory testing. Removal of the pituitary adenoma is indicated if a tumor is the cause. Medications that block hormonal effects can be used. This picture can be seen on page 861, showing the progression of acromegaly. Hypofunction of the pituitary gland is a rare disorder characterized by a decrease in the level of one or more of the pituitary hormones. The most common cause of pituitary hypofunction is a tumor. Other causes can include autoimmune disorders, infections, or destruction of the pituitary. A rare but serious postpartum complication known as Sheehan syndrome involves infarction of the gland secondary to postpartum hemorrhage. The most common pituitary hormone deficiency involves a decrease in the amount of growth hormone and gonadotropins. This decrease results in metabolic problems and sexual dysfunction. Decrease in growth hormone will lead to short stature in children. In adults, it will lead to an increase in bone breakdown, resulting in increased bone fragility and the risk of osteoporosis. Signs and symptoms of pituitary hypofunction will depend on the cause of pituitary failure and the hormones involved. If the disorder is related to a tumor, the patient can experience headaches, visual changes, anosmia, or seizures. Diagnosis of pituitary gland hypofunction is made by history, physical examination, and diagnostic studies. The mainstay of treatment for hypofunction of the pituitary gland is lifelong replacement of the affected hormones. Gonadal hormone therapy is typically offered, including testosterone for men and estrogen or progesterone for women, although associated risks may outweigh the benefits for some patients. If the disorder is caused by a tumor, surgery or radiation for tumor removal is typically performed, followed by hormone therapy. Diabetes insipidus, or DI, is characterized by the production of copious amounts of dilute urine. DI results from decreased production of antidiuretic hormone, which regulates the reabsorption of water in the kidney tubules. The most common forms of DI are central and nephrogenic. Central DI most commonly occurs after trauma or surgery in the area of the pituitary or hypothalamus. This can be temporary or permanent. Nephrogenic DI results from hypercalcemia or lithium toxicity, causing the kidney to be resistant to the effects of ADH. The patient will experience profound diuresis, often as much as 3 to 20 liters in every 24-hour period. Other signs and symptoms include thirst, weakness, and fatigue, often from nocturia. The patient will exhibit signs of deficient fluid volume, including tachycardia, hypotension, weight loss, constipation, and poor skin turgor. If untreated, the patient will demonstrate signs of shock and central nervous system manifestations, progressing from irritability to eventual coma, from hypernatremia and severe dehydration. Laboratory tests will be performed, including urine and plasma osmolality and a urine-specific gravity. A water deprivation test will be performed to confirm a suspected case of central DI. Replacement of fluid and electrolytes, along with hormone therapy, represents the basis of treatment for DI. In central DI, the hormone of choice to replace insufficient ADH is desmopressin acetate. This is available orally, IV, or nasally. For fluid replacement, hypertonic saline is used, titrated to match a patient's urinary output. Baseline vital signs and weight are important to accurately document and monitor throughout the therapy. Strict, hourly intake and output monitoring are essential to correct fluid losses and to titrate IV fluid replacement. Syndrome of inappropriate antidiuretic hormone, or SIADH, is the opposite of DI. Excessive amounts of ADH are produced. This results in fluid retention. Numerous factors can cause SIADH, including malignancies and tumors pressing on the pituitary. Signs and symptoms of SIADH include confusion, seizures, and loss of consciousness, accompanied by weight gain and edema. Hyponatremia occurs very frequently. Urine output will be diminished. This picture can be seen on page 863, showing a concept map detailing the pathophysiology of SIADH. SIADH is diagnosed by performing urine and serum osmolality tests simultaneously. Results should demonstrate a decreased serum osmolality and an elevated urine osmolality. This indicates the inappropriate excretion of concentrated urine in the presence of a dilute serum. Treatment of SIADH is aimed at correcting the underlying cause. This involves restricting fluids to 500 to 1,000 mL per day and administering sodium chloride, diuretics, and dimeclocycline to increase excretion of water. Closely focus on cardiovascular and neurologic systems and remain alert to the possibility of fluid shifts. You should promptly notify the healthcare provider of any change in level of consciousness. Electrolytes will be monitored closely, as often as several times per day, and daily weights will be measured. Hyponatremia produces an alteration in neurologic functioning and does require intervention. However, too rapid correction of this can result in permanent neurologic deficit. Careful monitoring and implementation of ordered fluids and medications are critical to a good outcome. Nursing care involves monitoring urine output and assisting with ADLs. Abnormalities in the thyroid gland activity and resultant changes in the levels of thyroid hormones are among the most common disorders affecting the endocrine system. The secretion of thyroid hormones is regulated by the hypothalamic pituitary thyroid control system. In other words, all three organs are involved in the closed-loop negative feedback system. In response to feedback received from the hypothalamus, thyrotropin-releasing hormone is secreted. TRH will act on the pituitary gland, bringing about the release of thyroid-stimulating hormone. The TSH will then act on thyroid cells, causing them to release thyroid hormones. A goiter is a greatly enlarged thyroid gland. One type of goiter is caused by a deficiency of iodine in the diet. Although the administration of iodine will not cure the goiter, it can stop continued enlargement of the gland. In the United States, this is a rare cause of goiter. A more common cause is an increase of TSH from lack of thyroid hormone production. The first sign usually noticed is an enlargement of the front of the neck. Later, if the gland continues to grow bigger, it will press against the esophagus and cause difficulty in swallowing. Goiter can be associated with increased, normal, or decreased hormone production. If goiter resulting from iodine deficiency is treated early, the growth of the gland can be arrested, and in some cases, the enlargement will eventually disappear. If lack of thyroid hormone is causing increased tissue growth of the thyroid gland, supplemental thyroid hormone can be given in the form of levothyroxine. A very large goiter that continues to grow and produces local symptoms of pressure, or one that presents the possibility of developing into a malignant growth or toxic goiter, will be surgically removed. Radioiodine can be given to destroy some of the thyroid tissue that is overproducing hormone. Iodine preparation should be given well diluted and administered through a straw because they can stain the teeth. Adverse effects of iodine preparations can include GI upset, metallic taste, skin rashes, allergic reactions, and epigastric pain. Symptoms of inadequate treatment include weight gain, dry skin, hair loss, impaired memory, and cold intolerance. Patients at the greatest risk for hyperthyroidism are adult women between 30 and 50 years of age. Primary hyperthyroidism is the result of an abnormality of function involving the thyroid gland itself, and it causes excessive circulation of T4 and T3. However, it is possible for only the T3 level to be elevated if the patient has Graves' disease or toxic adenoma of the thyroid. Secondary hyperthyroidism is typically the result of an abnormality in another gland, such as the pituitary gland producing too much TSH and therefore overstimulating the thyroid gland. Primary hyperthyroidism can result from an autoimmune disorder, such as Graves' disease, also known as a toxic goiter. Infections could be another possible cause. In addition, smoking is a risk factor for developing hyperthyroidism. The earliest symptoms of hyperthyroidism may be weight loss and nervousness. Symptoms can vary from mild to severe and may include weakness, insomnia, tremulousness, agitation, tachycardia, palpitations, exertional dyspnea, ankle edema, difficulty concentrating, diarrhea, increased thirst and urination, decreased libido, scanty menstruation, and infertility. If hyperthyroidism is not diagnosed correctly and continues untreated for any length of time, the patient can develop cardiomyopathy, heart failure, and cardiac-related death. The symptoms manifested by a patient with hyperthyroidism are the direct result of an accelerated metabolic rate and a speeding up of all physiologic processes. Medical diagnosis will be based on clinical manifestations of hyperthyroidism and the results of lab tests for thyroid hormone levels. The healthcare provider may also order an EKG to evaluate any cardiac dysrhythmias, as well as a chest X-ray to determine heart size. This picture can be seen on page 866, showing exophthalmos from Graves' disease. Hyperthyroidism can be treated medically by administering radioactive iodine and antithyroid drugs, mild sedatives, and beta-adrenergic blocking agents to control temperature, restlessness, or tachycardia. Antithyroid drugs will be prescribed as the initial treatment of hyperthyroidism. Methimazole is the main drug used. The patient must take the antithyroid drug at the prescribed time and then strictly according to schedule. Radioactive iodine, also known as ablation therapy, is the definitive treatment for hyperthyroidism. It destroys the thyroid tissue. The main disadvantage of the ablation therapy is the possibility of hypothyroidism caused by over-effective treatment. The hypothyroidism can occur immediately after the treatment or long after it has been completed. Therefore, the patient must have ongoing follow-ups. Dosage of the ablation therapy will depend on the size of the gland and the thyroid sensitivity to radiation. Most patients can be dosed and treated as outpatients. After treatment, all body fluids can be radioactive for a short time. Because the iodine circulates in the blood and is excreted by the kidneys, precautions must be taken when handling needles, syringes, and other equipment likely to be contaminated with blood, or when handling bedpans, urinals, and specimen containers likely to be contaminated with urine. All patients receiving radioactive iodine should be observed for signs of thyroid crisis that can result due to radiation-induced thyroiditis. Because many of the signs and symptoms of hyperthyroidism will mimic those of cardiac disease, whenever caring for an older adult, it's important to be alert to the possibility that these signs could be indicative of an endocrine disorder rather than a cardiac disorder. Adequate rest is essential to conserve strength, but it is difficult for a person with hyperthyroidism to relax and get sufficient rest. The diet of patients with hyperthyroidism should be sufficiently high in calories to meet metabolic needs. Patients who are being treated medically for hyperthyroidism must understand that they have an illness that requires ongoing medication and frequent monitoring to assess the effectiveness of treatment. Sometimes it can be difficult for the patient's family to accept and cope with the emotional outbursts and mood changes that will occur when the disease is not under control. Once hormone levels have returned to the normal range, these mental and physical symptoms should subside. Patients who do not respond well to antithyroid drug therapy, who are unable to take radioactive iodine, or who have greatly enlarged thyroid glands are candidates for a subtotal thyroidectomy. In the subtotal procedure, 2/3 of the glandular mass is removed. The remaining portion of the gland is left intact so that production and release of thyroid hormones can continue. For most patients, however, surgery is a treatment of last resort due to the potential complications of hemorrhage, hypoparathyroidism, and vocal cord paralysis. Preoperative nursing care is similar to that for any major surgery. If the patient appears nervous, tense, and apprehensive, this must be reported to the surgeon. These symptoms could indicate improper control of the thyroid gland and might predispose the patient to the postoperative complication of thyroid crisis. The head should be maintained in a neutral position postoperatively to relieve tension on the sutures. The patient will be watched closely for any signs of bleeding and swelling at the operative area, which can cause swallowing difficulty or airway compromise. Any rise in temperature, pulse, or respiration rate should be reported immediately because it could indicate a high level of thyroxine in the bloodstream. Other symptoms to be reported include persistent hoarseness and loss of the voice, which could indicate damage to the vocal cords. Tetany, which is muscular twitching and spasms, and thyroid crisis are other possible complications. Patient discharge teaching should include the signs and symptoms of the previously mentioned possible complications. Tetany will result from injury to or accidental removal of the parathyroid glands. Parathyroid hormone is important in regulating body calcium and phosphorus levels, and a deficiency of parathyroid hormone will produce muscle cramps, twitching of the muscles, and in some cases, severe convulsions from hypocalcemia. These symptoms represent a medical emergency and they must be reported to the healthcare provider at once. This is known as hypoparathyroidism. Treatment consists of IV administration of calcium gluconate during the emergency stage and then doses of calcium and vitamin D to maintain calcium balance within the body. Thyroid storm, TS, or thyrotoxicosis, is another possible complication of a thyroidectomy. In the postoperative setting, the condition can be caused by a sudden increase in the output of thyroxine, caused by manipulation of the thyroid as it is being removed. Another cause of TS could be improper reduction of thyroid medication before surgery. The symptoms of TS are produced by a sudden and extreme elevation of all body processes. The temperature can rise to 106 degrees Fahrenheit or more. Pulse will increase to as much as 200 beats per minute. Blood pressure elevates, respirations become rapid, and the patient exhibits marked apprehension and restlessness. Unless this condition is relieved, the patient will quickly pass from delirium to coma to death from heart failure. Treatment of thyroid crisis must begin immediately after the first symptoms are noticed, rather than waiting for laboratory confirmation. Measures must be taken to reduce the temperature. Cardiac drugs will be given to slow the heart rate, and sedatives like a barbiturate will be given to reduce restlessness and anxiety. Hypothyroidism can be caused by inflammation of the thyroid gland that damages tissue, iodine deficiency, decreased TSH secretion, hypothalamus dysfunction, atrophy of the thyroid gland, or treatment of hyperthyroidism that resulted in too many destroyed thyroid cells and therefore a deficit of the thyroid hormone. Genetic deficits can also cause congenital hypothyroidism, known as cretinism. Underactivity of the thyroid gland can be caused by a pituitary or hypothalamus dysfunction that causes inadequate stimulation of the thyroid, inducing secondary hypothyroidism. Children with hypothyroidism have delayed physical and mental growth and will become very sluggish within a few weeks after birth. Adults who have myxedema, or a very low thyroid production, have a decrease in appetite, but an increase in weight due to their slow metabolic rate. There is a tendency for patients with hypothyroidism to be lethargic and to sleep for abnormally long periods throughout the day and night. Other signs and symptoms of hypothyroidism include cold intolerance, constipation, abdominal distension, flatulence, impaired memory, depression, husky voice, thinning eyebrows, hair loss, brittle nails, easy bruising, fatigue, muscle cramps, numbness and tingling, dry skin, and non-pitting edema. Medical diagnosis is based on clinical signs and symptoms, as well as laboratory testing of serum levels of thyroid hormones and TSH. Hypothyroidism can be treated effectively with replacement of thyroid hormone. Patients with chronic hypothyroid will have very rough and dry skin, and they will need massage with lotions and creams to prevent cracking and peeling of the skin. It is important that this patient receive thyroid medication every day. Do not rush patients with hypothyroid or give them the impression of being impatient about their sluggishness. Forgetfulness, inability to express oneself verbally, and physical inertia are mannerisms that are a direct result of the thyroid deficiency, and you must recognize them as unavoidable for as long as the condition is uncontrolled. Although rare, a myxedema coma is a life-threatening condition. This can be precipitated in patients with hypothyroid by abrupt withdrawal of thyroid therapy, acute illness, anesthesia, the use of sedatives or narcotics, surgery, or hypothermia. Signs and symptoms include loss of consciousness, along with hypotension, hypothermia, respiratory failure, hyponatremia, and hypoglycemia. Treatment is with IV administration of levothyroxine sodium, fluid replacement, maintenance of an airway and respiration, IV glucose administration, corticosteroids, and warming measures. Thyroiditis is an inflammation of the thyroid gland. There are three categories: Acute can be caused by a bacterial infection. Subacute is caused by a viral infection, or chronic. This is the most common type, which is typically caused by an autoimmune disorder. Autoimmune thyroiditis, also known as Hashimoto's thyroiditis, is a chronic form that typically affects women between 30 and 50 years of age. The body produces antibodies against the thyroid, which in turn destroys the gland. There seems to be a genetic predisposition, and this is more prevalent in people with other autoimmune disorders, like RA. The patient will experience a painless enlargement of the thyroid gland, and they may have dysphagia caused by the inflammation. In the initial stages, the inflammation will overproduce thyroid hormone, and the patient will display symptoms of hyperthyroidism. Diagnosis will be based on laboratory tests, including serum thyroid hormone levels, TSH levels, and radioactive iodine uptake. Needle biopsy of the gland can also be performed. Acute thyroiditis will be treated with antibiotics. The subacute form is typically self-limiting, and treatment is symptomatic. The treatment for chronic thyroiditis is thyroid hormone supplementation to prevent hypothyroidism and suppress TSH secretion. The goal of therapy is to decrease the size of the thyroid and prevent hypothyroidism. Not all thyroid nodules are cancerous. It is estimated that 2 or 3 nodules in 20 are carcinoma. The use of ultrasound for screening can help make the determination if further testing is indicated. The most common form of thyroid cancer is papillary carcinoma. This accounts for 80% of all thyroid cancers, which occurs most often in younger women. The cause of thyroid cancer is unknown, but exposure to irradiation for the face, head, and neck conditions can increase the incidence. Family history and genetic makeup are also risk factors. The first sign of thyroid cancer could be a nodule found on a routine physical exam. Only 5 to 10% of nodules are found to be cancerous. Other signs and symptoms of thyroid cancer include fatigue, depression, and weight changes. These can easily be missed or attributed to other causes. The diagnosis of thyroid cancer is made by examination and diagnostic tests. TSH levels and other laboratory tests will be performed. A fine needle aspiration, in which the specimen of tissue is taken and analyzed, is the definitive test. The treatment for thyroid cancer is thyroidectomy. Multiple drug therapies are available for patients who are not candidates for thyroidectomy. Most therapies are intended to control tumor growth and not to cure the condition. Hypoparathyroidism is most commonly caused by atrophy or traumatic injury to the parathyroid glands. This can occur as a result of accidental removal or destruction of parathyroid tissue during a thyroidectomy. There is an inverse relationship between phosphorus and calcium. High phosphorus levels will decrease calcium levels. Signs and symptoms of hypocalcemia include mild tingling, numbness, muscle cramps, and mental changes, such as irritability. A Chvostek sign manifests as muscle irritability when the facial nerve is gently tapped. A Trousseau sign manifests as a carpal spasm, elicited by inflating a blood pressure cuff 20 millimeters of mercury above the systolic blood pressure. Tetany is a serious sign resulting from a lowered serum calcium level. In tetany, muscular twitching and spasms occur due to the extreme irritability of neuromuscular tissue. Medical diagnosis of hypoparathyroidism is established by clinical signs and laboratory data. Acute hypoparathyroidism with tetany will be treated with IV calcium gluconate to raise the serum calcium levels to a normal range and with vitamin D. Oral or parenteral administration of calcium salts can be used in the acute phase. In chronic hypoparathyroidism, treatment will be aimed at restoring and maintaining normal calcium levels in the blood. This can soon be accomplished by parathormone replacement therapy, administration of vitamin D in massive doses to enhance absorption of calcium from the small intestine, and oral administration of calcium salts. Remind the patient that therapy for hypoparathyroidism is lifelong, and advise them to wear a medical alert bracelet. Hyperparathyroidism is an endocrine disorder in which excessive parathyroid hormone is released, unregulated by calcium levels. A benign enlargement of the parathyroid glands or hyperplasia of two or more glands is the main cause of primary hyperparathyroidism. Secondary hyperparathyroidism occurs due to hypocalcemia that is due to deficient vitamin D. Hypercalcemia can occur with hyperactivity of the parathyroid glands because the hormone pulls calcium out of the bones. Signs and symptoms of hyperparathyroidism may be mild or severe. They are usually the result of dysfunction of other organs or tissues related to the high calcium levels. They can include dehydration, confusion, lethargy, arrhythmias, anorexia, nausea, vomiting, weight loss, constipation, thirst, frequent urination, and hypertension. Clinical context is used for initial diagnosis. Laboratory testing for persistent elevated serum calcium and elevated parathyroid hormone is the best test for the initial confirmation. On page 873 in box 36.2, you can see some causes of hyperparathyroidism. The treatment of hyperparathyroidism will depend on whether the condition has a primary or secondary cause and the severity of symptoms. Primary symptomatic hyperparathyroidism will be treated surgically to remove the adenoma or tissue producing the excess hormone. Asymptomatic primary conditions can be treated medically through infusions of isotonic sodium chloride and the administration of loop diuretic agents that promote urine excretion of the excess calcium. Phosphate therapy and calcitonin can be given to inhibit calcium release from the bone. Secondary forms of the disorder will be treated medically with vitamin D supplementation. Assessment for signs and symptoms of hypoparathyroid within 24 hours of surgery is indicated. Pheochromocytoma is a rare tumor of the adrenal medulla that secretes catecholamines. This is epinephrine and norepinephrine. The tumor is typically benign, but it can show malignancy in about 10% of cases. It causes severe hypertension and, if left untreated, can lead to death. Signs and symptoms of pheochromocytoma are related to the excess catecholamine release. These signs include tachycardia and severe hypertension, as high as 250/150. These can be intermittent or persistent. Profuse diuresis, severe headache, palpitations, nausea, weakness, and pallor can also be present. Pheochromocytoma is diagnosed by measurement of serum catecholamines and a 24-hour urine measurement of catecholamine metabolites. CT and MRI can be used to locate the tumor. Treatment is by surgical removal, often laparoscopically, of the tumor. This is known as an adrenalectomy. Addison's disease is characterized by decreased function of the adrenal cortex, resulting in a deficit of all three hormones secreted by the adrenal cortex. This will be cortisol, aldosterone, and testosterone. The major problems are related to insufficiencies of the mineralocorticoids and the glucocorticoids. Insufficient production of the adrenocortical hormones can result from a disorder affecting the adrenal cortex itself, known as a primary insufficiency, or from a disorder affecting the pituitary gland that stimulates the adrenal secretion, known as a secondary insufficiency. In the early stages of Addison disease, the clinical manifestations could be so vague and annoying to the patient, but not serious enough to consult a healthcare provider. Therefore, Addison disease can go easily missed or misdiagnosed. Later on, as the hormone insufficiency worsens, there will be severe symptoms associated with fluid and electrolyte imbalance and hypoglycemia. A major problem is depletion of sodium, which in turn causes the depletion of potassium, the depletion of extracellular fluid and potassium retention. The patient experiences generalized malaise and muscle weakness, muscle pain, orthostatic hypotension, and vulnerability to cardiac dysrhythmias. Insufficiency of the glucocorticoids affects blood glucose levels and causes symptoms of hypoglycemia. Diagnosis of Addison disease is made by laboratory testing. Blood cortisol and aldosterone levels will be evaluated, and an ACTH stimulation test can determine whether the problem lies in the adrenal gland or in the pituitary. Replacement therapy to provide the missing hormones will typically bring about a rapid recovery, but the patient must continue taking the hormones as a lifelong therapy. Prednisone will be given to replace glucocorticoids. Fludrocortisone is a synthetic adrenocorticosteroid to replace the mineralocorticoid aldosterone. Corticosteroids must be taken daily. Nursing management of patients with Addison disease includes intensive care and support during Addisonian crisis, prevention of problems related to fatigue and orthostatic hypotension, alleviation of GI problems, and instruction for self-care. Two important nursing measures are to provide both regular feedings throughout the day and adequate rest. If fasting is necessary for diagnostic studies or surgery, the patient with Addison disease will need IV glucose to prevent profound hypoglycemia. Stress, even relatively mild physical or emotional stress, can quickly bring on an Addisonian crisis for a patient with Addison's disease. The patient must avoid undue physical stress whenever possible and learn effective coping mechanisms to deal with emotional stress. The presence of cortisol in the body allows the blood vessels to function properly in response to epinephrine and other catecholamines by constricting. Conditions that decrease the amount of circulating cortisol will interfere with the ability of blood vessels to constrict. Patients with Addison disease have a decrease in or absence of adrenal cortical secretions, primarily cortisol. Physical stress from the flu or other infection or from surgery can send a patient with Addison disease into an Addisonian crisis. Steroids will be given to treat many autoimmune diseases, and the body can become dependent on the outside source of cortisol. If administration of the medication is stopped abruptly, acute cortisol insufficiency will occur. Decreased levels of cortisol result in decreased sensitivity of blood vessels to sympathetic stimulation. It is the sympathetic stimulation that maintains vascular tone. A lack of vascular tone causes vasodilation, producing hypotension. Other symptoms include severe abdominal, flank, or leg pain, tachycardia, nausea, and a change in level of consciousness. Closely monitor vital signs, blood glucose, and sodium and potassium levels. Adrenal crisis requires immediate fluid replacement therapy to prevent irreversible shock. Intravenous hydrocortisone is given along with sodium, fluids, pressors, and dextrose until the blood pressure becomes stable. Cushing syndrome is a rare disorder. The symptoms typical of Cushing syndrome are manifestations of excess levels of hormones from the adrenal cortex. This condition can be caused by excessive secretion of ACTH by the pituitary, a secreting tumor of the adrenal cortex, ectopic production of ACTH by tumors outside of the pituitary, and iatrogenic Cushing syndrome due to prolonged use of steroid therapy. This is actually the most common cause. The signs and symptoms of Cushing syndrome are caused by excessive levels of cortisol. They include painful fatty swellings in the intrascapular space, known as a buffalo hump, and facial area, known as a moon face, an enlarged abdomen with thin extremities, bruising after even minor traumas, impotence, amenorrhea, hypertension, and weakness due to abnormal protein catabolism with loss of muscle mass. The diagnosis of Cushing syndrome is established by laboratory findings indicating consistently high levels of free plasma cortisol rather than the usual 24-hour fluctuations. A 24-hour urine test should also be performed. If cortisol is elevated, a dexamethasone suppression test should be ordered. For the test, the patient will be given a steroid at night, and then blood and urine cortisol levels will be measured in the morning. Pituitary Cushing syndrome can be treated by Microsurgery on the pituitary gland. When surgical intervention does not restore normal cortisol levels, the medications or radiation could be used. The nursing care of patients with Cushing syndrome is primarily concerned with helping them cope for the many systemic problems caused by this disorder. You can assist the patient with psychosocial concerns presented by emotional lability and depression when they occur. The patient will need assurance that with proper treatment, these symptoms will improve within 2 to 12 months. Nurses in long-term care facilities must always be alert for adrenal dysfunction, especially among older adult female patients.